All right. Hello, everyone. We are just getting started. We're going to wait a minute or two for folks to get into the room. We had well over 100 registrants for this webinar, so we're going to truly give that minute or two. I hope everyone is staying warm. I know the East Coast got socked by some snow over the last couple days and a lot of school cancellations and everything else. So if you have little ones or furry ones, visit. Oh, I guess we're on a webinar. Never mind. I have to like come on to camera and have them wave hi, but you're on webinar. Sorry. All right. Yeah, we still have folks coming in, so we'll just wait another minute. All right. Looking like it came to a crawl. Awesome. So I will get started. Good afternoon, everyone. I'm Frank Hood, the director of Hep B United, and at the Hepatitis B Foundation, I'm our associate director of policy and partnerships. We're very excited to have you all here for our first Be Informed session of 2024. We hope you had a great start to your new year so far. Today, oh yes, I should go over these rules. I always forget. So this is a webinar, and so if you you are all on mute, but we do want to hear your questions. There is a Q&A box. Please do insert your questions into that Q&A box as you think of them as the presentation is happening. We ask that because sometimes we will answer questions live or in the chat as the presentation is going on. Just so we get as many questions answered as possible. Additionally, we'd love to sort of know more about you, the participant. So you are more than welcome, and in fact encouraged, to introduce yourself, who you are, where you're from, in the chat. We'd love to know about who we're talking to. And this session is recorded, and we will have the recording posted online and sent out via our newsletters over the next week. So if you are joining this session for the first time and you've not been to a previous Hep B United event, welcome. We're happy to have you. We like to say that Hep B United is a coalition of coalitions. So we are a national coalition that bring together state and local coalitions that focus on hepatitis B in their community. And so that can be focusing on hepatitis B as a specific disease issue, or working with communities that are more impacted by the disease. And we really, in our dozen years of work, we really have focused on helping our partner organizations come together and share best practices and really get the information they need to best serve their specific communities. And actually, I think today's topic is one of the best examples of like how our coalition is able to help other partners. We'll get into today's specific topic in just a second, but our Be Informed series launched last year. It is every other Tuesday at every other month on the third Tuesday at 3 p.m. We build out these sessions in a way that somewhat replicate like an echo format, where we really deep dive into a topic and then have some hard-hitting questions and then wrap it all up and get out the door within the hour. But it really is open to anyone and everyone. And again, thank you all for coming. And also to say that what we choose to talk about on these sessions are very much informed by our partners. So please do keep us posted about what you want to learn, because we will go find them. We are here in these first 5 minutes about welcome and housekeeping and description, but then we will turn it over to our two speakers and then really hold the end for Q&A and some open discussion. So I am thrilled today to have two of my colleagues from the foundation on, Beatrice Zovich and Holly Moore. And the title, Hepatitis B and Delta in the Harm Reduction Space, totally leaves a lot to be described about the just wealth of information and knowledge you all are about to receive. And in some cases, really is some of the first time we have seen information on these topics within this specific community researched in this way. And so really some like frontline information and takeaways. And I'm just super, super stoked about it. And then before I hand it over, just want to say that's 2 months from now, third Tuesday of the month at 3 is on March 19th, and that we will sometime in the next few weeks announce what the topic for that one is. But without further ado, I will stop my yapping and turn it over to my colleague, Beatrice.
All right. Thank you so much, Frank. And good afternoon, everyone. Thank you so much for having us today. As Frank mentioned, my name is Beatrice Zovich, and I'm joined today by my colleague, Holly Moore, who also contributed significantly to this study and will be helping to deliver this presentation. So we'll kind of split it into two parts. So the focus of the webinar is, as Frank mentioned, hepatitis B and Delta in the harm reduction space. And we will speak to the findings of a recent study that we conducted in partnership with a harm reduction organization in Philadelphia, Pennsylvania, in the United States. And the project was conducted in two phases. The first was an assessment of existing levels of knowledge and awareness of hepatitis B and Delta among people who inject drugs and the care providers who serve them, as well as an assessment of existing multi-level barriers and challenges for screening, vaccination, and linkage to care for hepatitis B and Delta in this space. And then the second phase was us actually conducting screening among 500 community members and working to connect them to care and vaccination as needed. So we'll be providing an overview of the project, and we hope that this webinar will shed light on some of the barriers and challenges that really impede increasing hepatitis B and Delta awareness, screening, vaccination, and linkage to care in the population of people who inject drugs, and how some of these barriers can be overcome and addressed. Next slide, please. Thank you so much. So just to provide a little bit of background for this study and what the impetus was. So in the United States, there are over 6.5 million individuals who have ever injected drugs in their lifetime. And as many of you are likely aware, people who inject drugs are especially vulnerable to bloodborne viruses, including HIV and hepatitis B, C, and Delta. And for those of you who are unfamiliar, we can do just a quick introduction to hepatitis Delta, if you might not have heard of it. So hepatitis D or Delta is a satellite virus that requires the hepatitis B virus to survive and replicate. And so it can only impact people who are already living with hepatitis B or who are at high risk for acquiring both viruses simultaneously. And if an individual develops chronic hepatitis Delta, then they have a much higher likelihood of developing cirrhosis and liver cancer than individuals who are living with hepatitis B alone. Prevalence rates of hepatitis Delta vary greatly, but it is generally believed that Hep Delta affects between 5 and 10% of individuals who are living with hepatitis B, and it is a really serious health concern that needs more attention than it currently has. So hepatitis C and HIV are highly prevalent among folks who inject drugs and have been well documented. And these infections can often exacerbate hepatitis B and Delta, but there's been significantly less research around Hep B and Delta in this space. There's been some literature which has found a prevalence rate ranging between 4 and 12% among people who inject drugs in the United States. And then and also since 2009, coinciding with the rise of the opioid epidemic, acute rates of hepatitis B have been on the rise, specifically among people who inject drugs. Epidemiological data for hepatitis Delta is very limited. As I mentioned, so many people are not screened for hepatitis Delta, so it's very hard to get accurate prevalence rates just in the general population and also in this specific population. And very low levels of awareness about both hepatitis B and Delta exist among both communities that are at risk for the viruses and providers who serve them. There was a study, a data set from the National Health Nutrition and Examination Survey from 2013 through 16, and that revealed that only 33.9% of adults in the general US population who were living with chronic hepatitis B were aware of their infection. And only 11.7% of respondents who answered the survey questions were aware of a past hepatitis B exposure. So very low rates of awareness in general. And this just indicates that there's a really strong need to increase awareness and accurate knowledge in this, in the general population and also among people who inject drugs, and to reduce transmission and incidence of these really serious viruses. Next slide, please. Thank you. So, so this brings us to the objectives for this study and the work that we try to do. So people who inject drugs have been considered a high-risk community for testing for hepatitis B and Delta for quite a long time. And now recently, as many of you may be aware, the CDC now recommends universal screening and vaccination for all adults in the United States, at least one screening per lifetime, and completion of the full vaccine series. But despite these recommendations, the diagnosis and prevention efforts for both hepatitis B and Delta remain pretty sporadic, which is something we're working on changing, but it's still, testing is still not done frequently enough. So we really wanted to, with the first phase of our study, we wanted to better understand some of the barriers and facilitators that might hinder or advance efforts to identify hepatitis B and Delta cases and susceptibility in order to move the needle on addressing these serious public health concerns within this population. And we also wanted to, again, evaluate existing levels of knowledge and awareness about the two viruses. And we wanted to assess educational needs and preferences so that we could ultimately create a communications campaign that would effectively reach this population and communicate, important information about these viruses. Next slide, please. Thank you so much. So in terms of the methods for this portion of the study, so first we, in addition to documenting barriers and challenges, specifically in the harm reduction space, we also wanted to document challenges just among providers in general who work with hepatitis B, who don't necessarily serve PWID. So for the first thing that we did was we put together and disseminated an anonymous online provider-focused survey. And we distributed this among Hepatitis B Foundation networks, as well as to providers within a Philadelphia health system. And this was meant, again, to document provider barriers broadly, not necessarily just those of providers who serve PWID. The survey questions were informed by a literature review and key opinion leaders, and we housed it on the SurveyMonkey platform and distributed it to US-based providers. And then in addition to that, our particular focus on the harm reduction space, we conducted 18 key informant interviews, specifically within the PWID community. So 8 of these interviews were with clients of the harm reduction organization that we worked with. 4 were with non-medical staff at the organization. So this included case managers and drop-in staff, and then 6 medical providers who work with this population as well. The medical providers, 2 of them were at the harm reduction space, and the other 4 were worked for other organizations also in Philadelphia, but for different harm reduction orgs. The participants who had lived experience did complete a very brief demographic survey and just answered some pretty simple questions about their age, race and ethnicity, gender identity, sexual orientation, primary language, and drug use behaviors. Again, all interview guides were informed by a literature search or literature review, and all participants were compensated $10 for their time. Next slide, please. Thank you. So to review the data analysis methods that we used. So in terms of the provider-focused survey that we disseminated, respondents were categorized into 3 different roles. So the first was public health and community workers, the second was clinicians, and the third was researchers. And we had a few different main outcome variables that we were measuring. So the first was barriers to hepatitis B and Delta screening, existing knowledge of hepatitis B and Delta, services provided for Hep B and Delta, and then we wanted to measure levels of confidence among the different types of providers in explaining hepatitis B and Delta test results and counseling patients who may have had positive diagnoses. So that was on the survey side. And then with the interviews that we did, all the interviews were recorded and transcribed verbatim. We created a code book in order to organize data, and all codes, again, were created using the literature review for guidance and a reading of a subsample of transcripts. and the codes were all defined, and coding and analysis was conducted using the qualitative analysis software in Vivo 14. We used independent double coding and intercoder reliability, which we assessed using a kappa coefficient. And then data was reviewed and organized into thematic categories. And as I mentioned previously, findings from this portion of the study were used to inform the creation of a culturally appropriate and tailored educational campaign, specifically for PWID at the HRO that we worked with, or harm reduction organization. And the campaign was really aimed at increasing knowledge and awareness of Hep B and Delta among community members for both clients and providers at the HRO. Next slide, please. Thank you. So in terms of the results that we found, so we'll start with a provider survey. So we had 56 people, providers complete the survey, and you can see the demographics of the folks who participated on the slide. All survey respondents were either, or the vast majority of respondents were either public health community workers. So this was things like case managers, community outreach workers, peer support providers, et cetera, or clinicians. And this included advanced practice providers, general practitioners, and hepatologists. We only had one participant who identified as a researcher, and they were a medical laboratory worker. You can see that 45% of folks had been in their role for less than 5 years, 20% between 6 and 10 years, and 21% for more than 20 years. And the majority did work in an academic institution setting. Next slide, please. Thank you. So in terms of the results of these surveys, so first, we really learned a lot about barriers to screening and vaccination. So again, you can see some of the results represented on the table again. As many as 67% of respondents encountered barriers with performing hepatitis B screening. And the biggest among these were not knowing if insurance would cover screening for specific patient populations and limited time and competing priorities for providers. Other commonly cited concerns were complexity of professional screening guidelines, concerns about patients' ability to manage a hepatitis B infection, and difficulty associated with discussing risk factors of hepatitis B with patients. We also asked about barriers to vaccination, and these included factors like patient hesitancy, challenges with completing the full series and loss to follow-up, again, confusion about insurance coverage, and the high cost of acquiring the vaccine with often little demand from patients to actually receive it. And then as many as 82% of respondents indicated that they faced barriers with hepatitis Delta screening. And the factors behind this were things like uncertainty about which labs actually performed hepatitis Delta testing, again, a confusion about insurance coverage, and complexity of guidelines, and then a lack of knowledge about the tests that are actually needed to screen for hepatitis Delta completely. Next slide, please. Thank you. So, and then finally, the last couple of outcomes we measured from the provider surveys, we did knowledge tests and found that only 7% of participants had a clear understanding of the groups that were at risk for hepatitis B. 62% of participants did understand the tests needed to test for hepatitis B, namely the triple panel, which is surface antigen, core antibody, and surface antibody, which we'll get into a little later. And then fewer than half of participants understood that the severity of hepatitis Delta co-infection with hepatitis B. So there was a lack of understanding that Hep Delta can really cause faster progression to more serious liver disease and liver cancer. 39% of respondents were aware of the tests that were needed for hepatitis Delta, which is pretty low, but 60% were aware of the high-risk groups that were particularly in need of hepatitis Delta testing. And then in terms of the services provided, only 41% of respondents screened for hepatitis Delta at all. And then when we asked about levels of confidence in counseling patients about hepatitis B and Delta diagnosis and explaining test results, the confidence of community health workers for both viruses was significantly lower than that of clinicians, which is perhaps unsurprising. Next slide, please. Thank you. So now to get into the interviews and the findings that we had from speaking specifically with folks at the Harm Reduction Organization. So there were several different emergent themes from these interviews. The first was knowledge and awareness of hepatitis B and Delta, which, unsurprisingly, we found a significant lack of among both community members and non-medical staff at the Harm Reduction Organization. There was a lot of confusion about different types of hepatitis, and there was a lot of conflation between hepatitis B and C. Many people had heard of hepatitis C, hardly anyone had heard of hepatitis B. In general, knowledge of symptoms, transmission, and severity of hepatitis B was varied, and there were different perceptions of risk that were found among community members. There was some knowledge in general that factors like housing instability and injection drug use can be risk factors for the different types of hepatitis. The most common myths that we encountered are that hepatitis B, there was a belief that hepatitis B can be transmitted in a similar manner to hepatitis A, namely through fecal or oral contamination. And then a lot of folks believed that hepatitis could be transmitted casually through casual contact or through the air. That was very common. Accurate knowledge of hepatitis C was quite high among many community members and non-medical staff, largely due to lived experience in many cases. And then for the providers that we interviewed as well, there was a lack of awareness about hepatitis B and Delta, and specifically about the prevalence of the viruses in the harm reduction setting. And there was also a lack of knowledge about the epidemiology of the viruses as well, and just where they could kind of be found and why screening was sort of justified. Again, there was confusion mentioned about the screening guidelines. And you can kind of see quotes illustrating some of these themes on the slide. And then a second emergent theme was stigma around hepatitis B and Delta. We really found that there's quite significant stigma in the harm reduction space in general, both internalized stigma among participants and then external stigma. I think it's well known that harm reduction in the United States is a point of contention in many places, and can often be a view that harm reduction organizations are enabling drug use. So this was certainly something that we encountered through speaking to folks. Several individuals felt that the knowledge of hepatitis B and Delta was too low for there to be specific stigma about them. The stigma was more surrounding HIV and Hep C, but some people did feel judged and looked down upon, however. And there was also one thing that we really encountered a lot was people having a lot of wounds and abscesses and stigma around those, particularly as the drug supply becomes more and more dangerous and it causes more and more serious side effects. A lot of people, because of wounds and abscesses, were unwilling to get a blood drawn, which is something we'll touch on a little later, but there was a lot of stigma around that as well. Next slide, please. Thank you. So just to go through a few more themes, another that we found was trust in healthcare providers, or that we asked about. And we did find that there is some level of mistrust of both medical and non-medical service providers among people in this community. There's a lot of concerns about confidentiality and privacy for folks. And there's feelings of not being listened to or taken seriously by providers, and just kind of having serious concerns dismissed and not addressed in a respectful way. Also, the theme of prevention. So again, a lot of people mentioned barriers to vaccine access and hesitancy around receiving the vaccine. There was a lot of confusion as to the number of doses needed to complete the hepatitis B vaccine series and the schedule for completion. Interestingly, one reason that was cited for vaccine hesitancy is the need for bodily autonomy. So as I mentioned before, as the drug supply in the US becomes more and more contaminated with different drugs, and people become less and less sure of what they're putting in their bodies. Refusing the vaccine is kind of one way to exercise control over what goes into their bodies. So that was an interesting reason that emerged for not wanting to get the vaccine. Also, just vaccine weariness in general. Everyone knows with COVID, people are kind of over vaccines. So that was definitely an issue that emerged. Again, cost was an issue, both the cost of acquiring the vaccine in order to administer it to folks and the cost of getting the vaccine. So, many people are not connected to doctors or to pharmacies. And even if they are, having to pay for the vaccine, is certainly an issue. And then, often vaccines and healthcare are just not really a priority for this community. Many people are really living day to day. They don't know where they're going to sleep tonight and where their next meal is coming from. So it's very hard to prioritize doctor's appointments and vaccines when you're just constantly living in survival mode. And then, of course, the loss to follow-up because of the need for multiple doses. I think that's seen in many communities as a barrier to the vaccine, but certainly in a transient community such as this one. Next slide, please. All right, thank you. So just the last couple emergent themes, and then I will just list out some takeaways that we had from this phase of the study. So we also just kind of asked about the current landscape of screening practices and barriers that were experienced specifically for screening and linkage to care for hepatitis B and Delta. Again, providers often mentioned that hepatitis Delta screening is not available at all labs in the United States. So currently only Quest Diagnostics and LabCorp kind of have the market cornered in terms of laboratory testing. They each have about 50% of the market, but Quest is the only one that performs hepatitis Delta screening. So, and hopefully that will change soon, and LabCorp will have the test available hopefully this year, but about 50% of the market is excluded from having this test available to them in the US currently. So there are two tests really needed for hepatitis Delta. The antibody test is the first one, and that just indicates if someone has ever been exposed to hepatitis Delta, kind of like the hepatitis B core antibody test. And then if that test is positive, then another test is needed, which is the hepatitis Delta RNA confirmatory test. The first test, the antibody test, is relatively affordable and relatively available. But the RNA test is really, really hard to access and very, very expensive. So that's definitely a barrier. Additionally, external referrals is really challenging for this community. So if someone does test positive for hepatitis B and definitely for hepatitis Delta, and they want to be referred to a specialist, there's a lot of challenges with that, particularly in this community. Things like long wait times, geographical distance from specialty offices, and concern about withdrawal for many members of this community really dissuade a lot of people from wanting to attend these appointments. Again, as I mentioned before, the need for phlebotomy and for venous blood draws is a big issue in this community, and there's definitely a need for a point of care test, which we'll discuss more in a little bit. And also, you have to, once you get your blood drawn, you have to wait for at least 24 hours to get your results. Whereas if there was a point of care test, you could get your results in 20 minutes, and that would make things a lot easier. Again, provider time and capacity are limited. And one interesting finding was that we talked to a couple of people who worked in street medicine teams who do kind of direct outreach to folks, who are living on the streets. And they have very strict requirements for what they can do. So they have specific funding streams, to provide basic primary care, to, perhaps inject mental health medications, to do HIV screening, things like that. So if they don't have a specific grant mandate for a particular type of testing, they won't do it. And they're also they're generally very short-staffed and short on time and resources. So it's not something that they can just easily incorporate often. And then finally, in terms of recommendations and needs from the community, there was a lot of enthusiasm for a targeted and culturally competent communications campaign. Some important things to highlight are that hepatitis can affect anyone in order to be not stigmatizing. And then including clear information about transmission, risk factors, viable testing practices, and behaviors that can and cannot prevent the transmission of hepatitis B and Delta was really important. It's also important to clearly outline the different types of hepatitis in order to clear up any confusion around that. And then it's a really good idea to balance information about risk factors in a non-stigmatizing way. So you can see one quote on here that kind of illustrates this well. People who work within harm reduction organizations and community members are told all the time, that they're engaging in risky behaviors, that what they're doing is not good for their health, that, there's risks to their mortality, just over and over again, hearing really negative messages. So avoiding that and finding a way to just kind of mindfully share about risk factors in a really non-judgmental way, to frame things in a positive light and with sort of messages of empowerment is really important. And then in terms of the kind of actual materials, just kind of handheld materials like flyers, brochures, fact sheets, and posters were really important, as well as palm cards, which can be incorporated into syringe kits. That was mentioned several times. And then folding information about hepatitis and other health risks into information about safe injection practices was also noted. And then in terms of educating staff members, having both physical and digital materials available, and also providing small kind of educational presentations. And then just one final thing was that folks had a lot of people mentioned that they had been to rehab and they had learned a lot of health information in that setting. So finding a way that could be another potential partnership avenue to work on incorporating education into that setting. Next slide, please. Thank you. All right, so this is my last slide, and then you get a break from me for a little bit. So this is just takeaways from kind of this first phase of our study. So just in summary, there is a significant lack of awareness for hepatitis B and Delta. There's a lot of stigma around harm reduction, and there are significant barriers to accessing services for this population. And there's a real need for a tailored and thoughtful education and awareness campaign. So some sort of recommendations and calls to action are increasing provider training, especially at the primary care and community health level, really encouraging clearer and more consistent screening and management guidelines, and incorporating things like double reflex testing for hepatitis Delta, where everybody who tests positive for hepatitis B is automatically tested for hepatitis Delta without having to call and request another test. That would be great. And it seems like AASLD is working on incorporating that into their updated guidelines this year and next year. So that's very positive. Again, stigma can really deter people from seeking needed care. And, previous research has found that a lot of stigmatizing beliefs and stereotypes about this community really can lead to lower quality of care and contribute to internalized stigma, again, like I mentioned before, and feelings of shame and embarrassment in this community. So that's something that really needs to be addressed. Certainly, really consistent political and financial support for harm reduction organizations is crucial for maintaining public health and really improving health outcomes in a non-stigmatizing way. I think we have a long way to go still towards that, but that's really necessary. Vaccine access, as we found, is very challenging and expensive. So doing sort of a one-stop shop model and administering the first dose of the vaccine in conjunction with the screening would be really helpful. So at least people receive something all in one visit, and that opportunity isn't lost. Again, a point of care test, which Holly will speak about a little more, and having a centralized screening location with good and flexible options for linkage to care for this population without having to go through the kind of arduous and rigid process for referring someone to a specialist would be really awesome. And then finally, having, so the CDC has recommendations for all adults to be universally screened and vaccinated for hepatitis B. If now the next step would be having the United States Preventative Services Task Force follow suit and also recommend this, as that is the body from which most insurance companies take their lead, and just seeing what a barrier insurance was among providers and confusion about insurance coverage, that would really help significantly. Having wider availability of Hep Delta testing at different commercial labs, and then really just how important it is to have more supportive and comprehensive social services for people who are struggling with addiction and all of its comorbidities, things like unstable housing and financial difficulties. This would help so much in order to have people really get out of survival mode and prioritize their health in the way that that they deserve. So All right, so I will stop there. Thank you so much, and I will pass it on to Holly to talk about phase 2.
Hello, next slide, please. Alrighty, perfect. And I quickly actually just saw something pop in the Q&A, and I'll mention that specifically a little bit in my section as well. So I love that those are already coming through. But hello, everyone. My name's Holly, and I'm going to talk a little bit about our second phase that we did for this project. And that was specifically working directly within a Philadelphia harm reduction organization to test 500 individuals for hepatitis B and D. So as Beatrice mentioned, existing research shows evidence that there's just a lot of inconsistent testing within the PWID, people who inject drug, population, and sporadic estimations for hepatitis B and Delta prevalence. So one of our goals was to try to not only raise awareness of hepatitis B and Delta, but to accurately assess the prevalence of these two viruses in this population specifically. And then additionally, we helped to facilitate for anyone who needed a connection to vaccination and management as appropriate. And then ultimately, we just wanted to use this as a pilot program for outreach and education and screening within the harm reduction setting, specifically in the US, and hope for that to provide a model for integration of this screening process in this population. So that's a lot of what I'm going to cover is kind of how we see this working long-term for other organizations. Hopefully y'all can learn from that. Next slide, please. All right, so you're probably asking, how the heck did we get 500 people to agree to do this? Well, we had a great team within the harm reduction organization that helped us with daily recruitment on site. We took about 20 to 30 names per day, and we're actually able to get this done fairly quickly. And I'll talk a little bit about why that was so successful in a bit. But we introduced a little bit of education about hepatitis B and D through the consenting process and then demographic survey process. A lot of times participants were actually really curious as we started asking more questions about your risk behaviors and demographics, things like that. So that kind of created a unique opportunity for education on site and in person, which was great. And then we asked general demographic questions as well as those high-risk behavior questions such as history of incarceration, hepatitis infections such as hepatitis C or A, injection drug use behaviors, and then like use of transactional sex and things like that. Those are just a few samplings. And then they met after that with our wonderful phlebotomist, Jason. I'll talk about him in a minute as well, where they did just a 3 milliliter venous blood draw that was sent to Quest, which is one of the labs that does hepatitis D antibody testing, which is why we use them, really important there. They would do first a hepatitis B triple panel test, which Beatrice talked about, that includes hepatitis B surface antigen, which would indicate if you have a positive current infection, hepatitis B surface antibody, which would indicate that a person has protection either from a past infection or from vaccination, and hepatitis B core antibody, which usually indicates a previous infection when also seen with surface antibody. We had a few instances where you would see it by itself as an isolated core antibody, and that would be needed to be sent on for further testing just to see if it meant that there was a past infection that was creating protection for the body or some fluke in not seeing surface antibodies, things like that. So in this case, we treated those as a positive infection, and we called, so like that reflex testing, that's not happening right now. So we actually, as a team, had to go in for any positive cases, call the lab and say, hey, we want to order a hepatitis Delta test, because as Beatrice said, you can only have hepatitis Delta if you have an active hepatitis B infection. So we would go in and ask them to order a hepatitis D total antibody test to identify whether or not they were also living with hepatitis Delta. And then finally, after that, we encourage participants to come back in a week to receive their results and discuss them with one of our staff members so that we could educate and then link them to care if needed. And upon completion of the blood test, participants were given $20 cash incentive, and then to increase loss of follow-up, and then 15% cash incentive when they came back. That I'll get into again a little bit more later, but there are definitely pros and cons with using that incentive, but just wanted to mention those 2 points where they were given incentives. Next slide, please. Thank you. All right, so I'm going to go a little bit into data analysis, but this is still in progress. So this is phase 2, and we are still undergoing some of the statistical analysis, but I'll at least give you a brief overview. So first, demographic information and testing results were extracted from our software platform, ODK. And then all data was cleaned. And then current statistical analysis, what we're looking at, there's some specific statistical names in here, but just basically what we're trying to figure out is what are the odds ratios between different behavioral risks factors and then different HBV blood test results and blood markers. And then additionally, we're going to use a logistic regression to identify any possible predictors for infection as the form of positive surface antigen or isolated core antibody. And so that's a little bit, I'm sure it's very complicated, so I'm not going to delve really deep into it, but that's what we're looking at in the future. And I'll dive a little bit into just some very surface level results of what those looked like for us so far. Next slide, please. All right, so in terms of our basic results, we screened 513 individuals. This was a group effort, but very positive to have gotten that many people in such a short amount of time and let them know their Hep B status. So we were very excited about that. Out of those 513, 10 tested positive for hepatitis B surface antigen, which means they have a current infection. 10 also tested positive for isolated Hep B core antibodies. So again, we treated this as a positive infection just in terms of ordering that Delta antibody test just in case. And then in terms of the discussions that we had with those participants, it was, hey, we're probably going to need to do some repeat testing and see, if this is just a fluke or if you have hepatitis B DNA, that would be another test to look at as well. So we found one positive Hep Delta antibody result. In this case, the participant was linked to care for additional testing to confirm the hepatitis Delta DNA test. Like Beatrice was saying, this is a little difficult to actually obtain and very expensive. So we, even as an organization with very robust services, have limitations. So we tried to link to people who would be able to confirm that for this participant. And then about 70% of participants were protected, meaning that they showed presence of Hep B surface antibody. And then 18% of all participants had a previous infection, and 53% of all participants had been fully vaccinated. And then lastly, a quarter of our participants did not show any presence of Hep B antibodies, but 10 individuals were actually able to complete their first vaccine dose with the Philadelphia Department of Health immunizations team. They come on site to this harm reduction organization first Tuesday of every month. So that was a little win for us there. We could get some people on the track for vaccination. And then finally, we saw 89% of all participants return to receive their results and discuss next steps with us. So that was a really great way for us to get some people back. Next slide. All right, so from these results and preliminary analysis, these findings show that compared to a similar study that was conducted about 2018 within the PWID injection drug population in Philadelphia, the prevalence of Hep B and D has remained consistent at about that 1.9% over the last 5 years. But other findings show evidence that vaccine protection has actually increased and virus susceptibility has decreased. And this shows positive trends for vaccine uptake. And I know there was a lot of vaccine waning around COVID and things like that. But in terms of these results, that's really a positive outcome that we saw based on these results. And then initial correlations that we saw show that previous incarceration indicated in demographic surveys is the most correlative factor for a current infection. And then additionally, current experience being unhoused or previous experience engaging in transactional sex has indicated a demographic survey, as indicated in a demographic survey, is a correlative factor for an isolated core antibody positive test. So those are just some of the initial findings that we've learned. And next slide, please. And finally, got lots of lessons that we've learned in terms of being a pilot program. I think this is probably one of the most important things to take away from our presentation is, what have we learned that can be used positively and replicated again? And what are things that need to maybe be adjusted a little bit? So we're fairly successful. But first off, I have to mention that our phlebotomist, Jason, was the entire reason this thing was as successful as it was, because any venipuncture blood draws for the PWID population is really difficult for both the research team and the patient, just because of the status of the veins. And so having someone who has had experience in that is really important. But then additionally, like Beatrice said, a point of care test does also kind of take away that barrier, right, of being able to actually do it without a venipuncture test performed by an official phlebotomist. And so I'll get into a little bit of, we're going to call to action for that to be approved in the US, hopefully sooner rather than later, specifically for this population. But I had to shout him out for that. And it would also kind of reduce the loss of follow-up with patients having to wait for the test results to be analyzed by the lab and then given a week later. So that would have helped us specifically within this population. So another key part of making this study successful was the use of incentives. In the harm reduction space, incentives are commonly used to encourage preventative health behaviors. And this contributed to how quickly we were able to recruit participants and the high return rate. And although we use cash, there are other options like convenience store gift cards, credit for other services offered at the organization. And then this did help initially, although we did definitely see some drawbacks. There's pros and cons. These participants are fairly desperate for, you know, some support financially to get food, or, you know, a lot of times they're just thinking about how to keep from feeling those withdrawal effects as well. So we had some people who tried to come in repeatedly to be screened multiple times under different names and birth dates, or come back for results multiple times, and even try to forcibly take some incentives. And so there was a little bit of pros and cons and some learning there. But ultimately, with the goal of screening and making participants aware of their status, this was a key part of our success. And then finally, there were some difficulties linking positive infection participants to appropriate care in the same harm reduction setting, since there were so many restrictions on who could see on-site medical staff. At one point, we were told it could only be people who are HIV positive, and then it added on to anybody who's HCV positive, Hep C. But so it was a little bit up in the air of if we could get these people to be seen by the on-site providers. So there's a little bit of restriction there. And so we a lot of times also had to do some external referrals and try to support them with transportation and follow-up and things like that. But again, with this community being very transient and sometimes here, sometimes not, it was difficult to connect them to care when appropriate. Next slide. Last one, y'all. We're almost there. I know we've probably given y'all a ton of information, but I just wanted to point out our overall recommendations and calls to action. Completing this study, there is a significant need for approval of a point of care test, especially if you're working in the harm reduction space. It's just going to make so many things a lot easier and really help accessibility for Hep B and Hep D screening in this population. And then this program showed a lot of efficacy in offering multiple services at one trusted organization site. So this is kind of what we were talking about a little bit with the one-stop shop, where, you know, there's a testing service that's available regularly within the site, having someone who can be there and counsel through the results, and then having ability to link to on-site medical services and or vaccination. So it's kind of that model of being able to encapsulate the whole care continuum within one trusted site where people are, it's accessible for this population. So that's kind of what we mean by that. And then finally, the last model I wanted to highlight was, again, that partnership between the Philadelphia Department of Health Immunizations and the Harm Reduction Organization. I think this is something that could be replicated in multiple different areas within the US, of linking to local health government organizations to kind of help lessen the burden on the harm reduction organization staff directly, but still providing that accessible point for vaccination within the trusted community for the PWID population. And then just want to say, once other statistical analysis is completed, we'll probably add to these recommendations, but we believe that these are the steps that will make Hep B testing and Hep D testing more consistently accessible for the harm reduction population. So hopefully that helps y'all learn a lot. And I think that's it for us.
That's it. As if you didn't just drop 50 minutes of fantastic knowledge on us. Okay, so we have 10 minutes. We got a couple questions in the Q&A, so we'll turn that over to you all to answer. I have two questions I wanted to throw out there with moderator's prerogative. One, which I think should be answered last after everything else is answered, is like, what's next beyond just the statistical analysis. Just I'm curious to hear where you all are thinking, kind of next steps. So that's at the end. I would love to hear a little bit more about if that financial incentive really is what got you 89% follow-up, if that was it, because that is a significantly high amount of follow-up. Way to go. That alone is a massive win, and on top of everything else. So would love to hear some more about that. And then we have 3 other key questions in the Q&A. So whoever and whichever you wish to answer first.
I'll just answer the few simple ones I see in the Q&A. Was there loss to follow-up among clients tested? Yes, there was. I mean, we did have a really high retention rate in terms of getting people to come back and discuss the results with us. But there's always going to be people who, I mean, not even that they didn't want to show up, but a lot of times, you know, they get into trouble with the law. A lot of people ended up having to go to jail for numerous reasons or hospitalized. That was a few times people would come back even after the study was completed. And, you know, we still work with the harm reduction organization, and they've been helping to still get those results even after the conclusion of the study to those who want it. But there's a lot of factors that, you know, affect whether or not they're able to come back regardless of their desire to. And then, yeah, there was still, I know you wanted to answer it at the end, Frank, but we did still have a very significant portion of people who were curious, and that's why they came back. But obviously, it boosts the likelihood that they'll come back more quickly, I guess, with the financial incentive. So there's definitely, I don't want to attribute all of it to incentive, but it helped a little bit. And then did the research look into race? Yes, that was one of the demographic questions. And I think that's part of still what's going on in statistical analysis. So I don't want to say anything like too formative on that yet, but we did answer a lot about race in terms of, or ask a lot about race in the survey questions.
I can kind of speak to the next steps. Next steps are getting this out. So we are working on 2 manuscripts, one about each phase that we presented today. The one about the first phase is in pretty good shape. The one about the screening still needs some work, but we're hoping to submit them to journals. We wrote an abstract, and also each one will have an abstract that we'll submit to various conferences. One has been submitted for the World's Hepatitis Summit in April in Portugal. And then we'll likely pursue submissions to AASLD and the International Network on Health and Hepatitis and Substance Use as well.
Exciting. Well, that all got answered quickly. So I will go back to my list of other things. I have like a page and a half of notes, y'all. What were you most surprised to learn through this process?
So I think I can just answer. Sorry, I just see one quick question in the chat about which is most deadly.
I see that there.
Sorry.
Yeah, thank you.
Yeah. So I think I can just do, and y'all can feel free to jump in too, but I think they're all pretty dangerous. So hepatitis B is our area of expertise, but hepatitis A tends to resolve on its own. It's generally a acute infection. So most adults with a generally healthy immune system will recover on their own. But hepatitis B and C are the ones that have the ability, if someone can acquire them and they can recover on their own, usually within about 6 months to a year. That generally happens in the case of hepatitis B with adults who have a healthy immune system. With children, though, that's where hepatitis B becomes most dangerous because children's immune systems, particularly infants and then young children's immune systems, are not developed enough to fight off the virus. So that's where hepatitis B can become particularly dangerous and develop into a chronic infection. Hep C I know less about, but I believe it's kind of similar for Hep C as well. The main difference is that Hep C has a cure and hepatitis B currently does not, but hepatitis B has a vaccine and hepatitis C does not. So it's kind of a weird reversal, but.
Yeah, and I think just to add on to that, you know, when I first started working for Hep B Foundation, I found out about Hep Delta, and I was like, oh, this is something a lot of people don't know about, but that's probably, as we've discussed, the deadliest form of hepatitis, but linked to B. So there's like an added layer there, right? Is if you have B or D within B, then that adds another layer of damage and possible disease in the future. So that was a great question, though.
This is a great question. And I'm realizing it's only to hosts and panelists. The question was, of all the different hepatitises, which is the most deadly? The other kind of consideration when thinking of B versus C is that someone living with hepatitis C, their liver primarily progresses through standard fibrosis stages. Like you see a scarring of F1 to F2 to F3 to F4, and it is a fairly straightforward progression. Whereas sometimes you will skip through some of the fibrosis creation within B and get to a faster moving like liver cancer or liver failure diagnosis through some other mechanisms. And so it is, I think we can make the argument that yes, it is more deadly, but there are also some higher risk factors for like dangerous and fatal issues in that for hepatitis C, you sometimes have a few more chances to catch it through liver scarring, whereas sometimes you'll skip some of that liver scarring for B and really jump right into failure. So great question. Yeah. So looking down at so I was curious, just like anything you were sort of surprised by, good or bad, through this process. I mean, I suspect you came up with a what you thought might happen during your testing of 500 people. What surprised you?
I mean, I would say we actually didn't encounter as much hepatitis B and Delta as we anticipated. So it was actually lower than we initially thought. Yeah, so I think, I mean, that was a big surprise. There's been really not that much research on certainly hepatitis Delta. And like, if you read, prevalence rates, depending on the paper that you read, can fluctuate anywhere from like 3 to 42%. So there's, just no one is being screened for it. And there's just wide ranges on how many people are living with hepatitis Delta. But there has been, I mean, maybe still a minuscule amount, but a decent amount of research on Hep B or Hep Delta in among people who inject drugs since maybe about 1980 or so. And those rates have fluctuated widely as well. But so we did expect, I think, to find more than one case, but yeah, so there was that. And also just how many people are vaccinated. I mean, that was really great. And it was over half of folks were vaccinated and had immunity. So yeah, I think that was a really positive finding, but also, and to the point about like adults being able to clear, if you have a healthy immune system, being able to clear hepatitis B as an adult, 20%, like almost 1 in 5 people had hepatitis B in the past and had cleared it, so had immunity from it. So that was, even though it would be preferable to have immunity through the vaccine, that's still good that they, have protection from it through past exposure. Holly, feel free to share other.
Yeah. I was just quickly going to add on from my own personal reflection. I was happily surprised that so many people that I interacted with, I said a lot about incentives, and I feel like I should have balanced that with my own personal experience of interacting with these folks day to day. And a lot of them were actually very, concerned for their health. And I mean, we know that addiction is its own beast. And so aside from that and what they're dealing with that, it's, what can I do to keep myself healthy otherwise? Like that was a big concern for them. And so it's like they actually wanted to learn, and they didn't know a lot about hepatitis Delta, but they didn't just take it as, oh, it's another thing I don't know about. It was, how can I learn? What can I do? And so once they heard about it, they were more likely to, engage in conversation, come back for results. We had a lot of questions on the results discussions, which was really, I don't know, it made it feel, like we were making that impact for this population. And so I would say, as another recommendation, don't if you're going to do this in your own organization, try to approach these in a non-stigmatizing way of just being open to a conversation. And I feel like in this realm, we're probably, everyone listening here is going to be non-stigmatizing and have really open discussions. But I think I was very happy about how many discussions I had that were.
Yeah, I was gonna say I've seen some other incentive programs, and I'm not like some of them get up there, but for $50 to get close to 90%, that really is surprising. So I really do feel like what a great kind of message to end on of like, you know, we actually had some really, really interested people about keeping care of their health. And at the end of the day, that's really all what we're trying to do is help folks take care of their health. So thank you. I can we went the full hour. I'm gonna wrap it up right here. Thank you all for attending. Thank you, Holly and Beatrice. For presenting. Thank you, Shreya, for slides and all the other things that go to help make this happen. We hope to see you all in 2 months, as well as that other HBU pieces or happenings, and keep an eye out for this recording. And don't hesitate to reach out to us with any questions around what your org could be doing around Hep B in this community. So thank you very much, and everyone have a great rest of your Tuesday.
Thank you so much. Take care.